When I take history from the patient, I ask myself a question: where is the site of symptoms? Which joint suffers? And this is easy because the patient tells me straight away, hip pain, or she points at the joint line. Okay? So we know that this is hip-related pain. Easy? Simple? Step number 2, what is the functions aggravate the pain? She said that praying position like ruku'ah, walking, and sitting if sustained. From your mechanical understanding, what is the common direction of movement in praying, in walking, in sitting for the hip? Flexion. So when a patient gives me information, I want to translate it into movement direction. So 1, I know the site, the region of the problem. 2, I want the direction that increase the problem or the aggravating factors. Which direction? Walking, praying, so it's flexion. So it's a hip complaining in tasks with flexion. Simple? Back to the story. We start the physical examination with active range of motion testing. So when I tell my patient, show me your active flexion, all right? This is part of examination already. Range of motion test. What happens? I observe when the patient do the flexion, straight line. That is one block. Repeated flexions. Okay? What this pattern, if you see my patients, what this observation tell me? What the conclusion you have from this pattern? In active range of motion, show me the movement that hurts you, do the praying position in front of me, push through that. So what this movement, where the flexion happens, thoracic, lumbar, or head? Head. Lumbar, it's like posterior tilt or like punch. This is the lumbar, like the slouch. But the lumbar is all straight and this is the hinge. It's moving. Is that enough? I can't keep the front straight. And I noticed that for a reason he was in the front. And when I told him he would be over it, I went back. I'm not sure if this is good. So now I want you to recite to your colleagues please and show them how you do the movement with the straight front and push from the head. Yes, that's it. Can you see that? Can you do it 3 more times with the same pattern? And please fail as much as you can. We know that you are a healthy fit guy, but this is not needed now. So this is a problem with movement. Especially in Osama, think it as a pattern. No flexion other than this way. This is healthy or not? Relax, Osama. This pattern, this observation for a patient is good or bad sign? Not normal. This is a healthy movement system with many choices for the flexion or single choice. So I know that from this observation, you must be having a control problem. Because no option to flex from any other participant, thoracic or lumbar. Okay, so what's next? Maybe second comment, be close. Are you okay so far? So now I started site of the problem, hip. Aggravating factors, flexion. Control kinds of problem. So the problem here is not mobility of the hip. It's moving too much. So the problem is controlling the hip. Does it make sense? So the joint is not restricted, so I need mobilization. The joint is overloaded with overloading mechanical inflection. So I don't need to move more. I need to control. Are you so far? So when the patient tells me history, site of symptoms, factors increase the symptoms, kind of problem, mobility Good or bad? Not normal. Are you agree with me so far? Let's go to next step. So now we know that we need to assess, we need to diagnose what's around the hip is a problem. So, a small step back. This is the hip joint. Which is which? Stabilizers in the frontal plane, which is flexion extension, right? Who are the stabilizers I need to know? When it comes to flexion, we have the iliacus. Concentrically do flexion. Eccentrically do extension. So when I needed to control, I needed in an extension symptoms, like kicking back. Easy? The other way around. I have another stabilizers around the hip called deep glute max. Concentrically, it did extension. Eccentrically, it do flexion. Right? So when I have a flexion aggravating symptoms, I call the deep glutes. Does it make sense? Because we agree that the muscle we need for control is the eccentric action. So I look for problem in flexion, I need to explore the stabilizers. In this plan, whether flexion or extension. So both do the two movements, like iliacus do flexion, and eccentrically, deep glutes do flexion. So what is the priority in this situation when I want to train control? The eccentric function. So the choice will be deep glute max testing and the training. Are you okay so far? Good. The other way around. Which is which? As for the mobilizers affected, we have mobilizers doing a flexion, which are something wrong here, right? Good, that's your alert. So now I want your input. I want your help. I will write it again. So, who are the mobilizers? I will just remove this. I need two mobilizers in flexion. Rectus femoris and ITB and sartorius. Isn't it? So, as for the extension, who are the mobilizers? Superficial glutes, because deep glutes is stabilizer. Superficial glutes is a global mobilizer for hip extension, right? And we have the hamstring, two-joint big mobilizer for extension, right? So in this picture, long, big mobilizers. ITB, rectus femoris, hamstring. So these are the mobilizers I explore around the hip, right? So these are the stabilizers. You notice it's smaller and deeper. Okay, makes sense? So we still have a job. Remind me, the patient has a problem in flexion or extension? Flexion, right? Sitting, praying, and walking. So all the problem reported when the hip in flexion. So now we know the mobilizers contributing to flexion and mobilizers contributing to hip extension. Which group in these two lines you will choose? Group A, mobilizers doing flexion. Group B, mobilizers doing extension.
Now, we left the stabilizers, we're talking to mobilizers. We need to know which mobilizer I need to assess and train. And we agreed that flexion, we have mobilizers doing flexion. And we named these. We have mobilizers involved to do the extension. But the problem is flexion. Which your target? Group A or Group B? Hands up to mobilizers in flexion. Be like, okay. Hands up in mobilizers in extension. Some people didn't raise hands at all. What do you mean? You have a time to diagnose and treat all? It's okay, but if you have session time. So, remind me, the guys who raised their hand in extension. What is the problem? If I have a problem with flexion, which group, flexors or extensors, are doing too much? Right? So the question again, if I have flexion problem or flexion-related problem, muscle-wise, who are the muscles concentrically doing extra? Flexors as mobilizers. So in this case, rectus femoris, ITB, sartorius are doing extra flexion. Iliopsoas? Okay, so that's a good question. According to the Kinetic Control classification, iliopsoas is divided to psoas major and iliacus. They are not the same. Psoas major is local stabilizer. Iliacus is a global stabilizer. So it's a flexor, but stabilizer. So that's why we put it in the first with the stabilizer group. Are you okay? So again, this is a stabilizer. We have the iliacus as flexor. Rectus femoris as flexor, but mobilizer. Anyone is confused? So, if you are not confused, people who select the extensor as mobilizer, this is not the right answer. How? Because the problem with mobilizer is different than the problem with stabilizer. If I have problem with flexion, some muscles didn't do extension to counterbalance the over or the uncontrolled flexion. So when I look in the opposite group, I need the responsible team that left their job to other group that overdo the job. Make sense? So according to the function, I diagnose the problem. In the normal happy situation, I do the hip flexion with whatever the flexors, and the other group break. So the other group works oppositely to control, right? You know the lower cross, upper cross and lower cross? So in the normal happy situation, flexors and the extensors should be working, brake and accelerator with same balance. If this harmony didn't happen, there is a problem. How this harmony didn't happen? One group become underactive, so it let go. Okay? Control deflection is extension, isn't it? So extensors didn't control the flexion, didn't do enough extension. Easy? Easy? They didn't do enough extension to balance the flexion. So which movement happened too much? Hip flexion. On the other side, in the response of this, one group needed to do the function all alone, the flexion, mobilizers. So mobilizers overactive When they are angry, they get overactive and tight. Stabilizers, when they are angry, they are lazy and I will not do, whatever the consequences. So one group didn't work enough to balance other group that worked over and over. So to set the rule, what is the site of the problem? What is the direction of the problem? In the same direction, which is flexion. Who are the stabilizers? Who are the mobilizers? In the same plan, whatever flexion or extension, okay? Who are the stabilizers generally? Who are the mobilizers generally around the hip? Then I select which is which. Which group I need more activity from it. Flexor as a stabilizers or extensors? No, I'm asking. Extensors. I need more activity from extensors to balance the overactivity of flexion. The second question, which muscles doing more than needed of flexion? It must be flexors. Stabilizer or mobilizer? Mobilizer. How did I know? Because I learned it from the function that the response of pain to mobilizers to overdo. The response of pain to stabilizers not do. So when I have a problem, this is uncontrolled flexion. Too much flexion. So which muscles do too much flexion? I look for flexors called global mobilizer. In this case, it's rectus femoris, ITB, and sertorius. Right? So if muscle doing too much as a part of management, I need the control group. So I look for opposite group. I need extensors, right? Called stabilizers. To activate, to balance the flexion movement. Hands up if you get it. Hands up if you don't get it. So may you tell me which part you are confused in? Glutes? Need to be active, right? Yes. Yes. So you know who is the mobilizer around the hip? You know this? So why they are overactive? So they will need what kind of training? Exercise or stretching? Activation or stretching? Stretching. Are we all okay? Now you okay? So it overdid. So it's overactive. So they will need what kind of training? Exercise or stretching? Activation or stretching? Stretching. Are we all okay? Now you okay? So it overdid. So it's overactive. So I want to inhibit. Less activity from mobilizers mean stretching and extensibility. Right? Less activity from glutes on the other direction means I need exercise in the form of activation. So they are opposite in function and the opposite in retraining. Have this answered your question? Why they are not involved, right? So my question is, my colleague is asking, I also have a mobilizer for extension, which is the hamstring. And if I kick, I need also the hamstring control the flexion. Same applies like the glutes. Make sense? So I need the hamstring in which task? Force demand or easy task? Force demand. So your thinking is right if this is an athlete. You need length from the hamstring to control the flexion on the top of the deep glutes. But if I'm low threshold, low force needed, I don't need hamstring to be involved. I spare it to high function. Have this answered your question? So it's not my priority. That's why it's a low threshold. It's an easy task. I look for stabilizers first, right? If there is a problem with mobilizers, it will be overactivity, so I will target to stretch. I can strengthen later, okay, the eccentric function, but with athlete, this is not my problem now. Mobilizer should be extensible first, flexible, and then you can train its activity. Unlike the stabilizer switch off. So this is a priority to activate. Does it make sense? So now, quick refresher. What dysfunction we find with global stabilizer? Inhibition and delayed activity, segmental translation, overactivity and tightness. Hands up for number 1. Hands up for number 2 or 3. You okay with number 1? Number 2? Segmental translation? Okay, so local stabilizer is responsible for local translation. Okay? But I am asking about global stabilizers. Global stabilizers are not segmental. They are global. So they don't care. They are not responsible for segmental control. They control the movement, not the segmental translation. So number 2 is the homework of local stabilizer and not global stabilizer. Have you got my question, Osama? All is okay? So dysfunction, impairment, uncontrolled movement we find with global stabilizer when they are switched off. Are we okay so far? Next question. What dysfunction we find with the global, it's repeated, with the global mobilizer? Inhibited and delayed activity, translation, segmental, overactivity and tightness. Right? Good job. Anyone is not sure about that this is answer number 3? We are talking general. When it comes to mobilizer problem, it overact, so it's tight, okay? According to the patient case, which movement direction is impaired? Frontal, like flexion and extension, sagittal, or transverse? Right, sagittal, flexion, extension, right? Which is flexion in particular. Done? Type. Step-by-step diagnosis and management. Site of the symptoms taken from the subjective examination. We did it already, right? Which is the hip. Direction of uncontrolled movement. It's the direction where the symptoms increase. In this case, it was flexion. Perfect. Detect global stabilizers around the hip. Iliacus, deep glute max. Prioritize the stabilizer with eccentric roll equal flexion. I prioritize the stabilizer that eccentrically do flexion, the direction of problem. Deep glute max. You got me? You know how we think about it? So I select the muscle group, stabilizer, mobilizer. I decide I need activation or stretching, and I start to, within the stabilizers or within the mobilizers, target the muscle concentrically doing a flexion, or eccentrically doing a flexion, eccentrically doing a flexion. That's why my priority to test and activate deep glute max, because it's eccentrically doing hip flexion, and this is the site of symptoms. Are we okay? So now we want the tested lab practically. I need a model. I need a model called Osama. I tried to leave it to him, but he didn't give me a chance. So now it's a practical test. We need the plinth. The test that I will talk about is already homework done with Sarah Morton and Mark Thomas. So it's not starting with. I think could you please get it here, little bit with me, and a little bit of this. Like, so now I will ask the patient, Sarah, please hug the patient. Half full. Half full, no. Like this. Your tongue on your left, and the rest is hug the patient. You are on the job. Ideally, this leg should be high. So now I want you to lie and bend with your upper body. No, with your upper body. This position, hug the bed. Exactly. Position four, hugging the bed. Let's say Osama has a problem in the right hip. Okay? So I want you to just hug the exactly. Now I want to test the deep glute max. Concentric, isometrically, and eccentrically. Oh, it's a test. So I want to check the scapula and the active in all parts. This is an information. You agree with me? What does the deep glute concentrically do? Action, and extension. So at this point, may I do first scapula, relax, and relax. So I want the patient to do like this. To extend the knee, so they use the hands. Relax. I just want you to kick from the sitting there. Again, we pushed by the hands. So this is a way, pattern, the patient showing me that he's using his hamstring over active back. Does it make sense? So now I educate the patient. I want you to do kick. Like this. It's like this. If you extend that class, it doesn't matter, but it's like this. You push from the sitting. Not like this. Raise it up. Again, I will teach you the trick. Because this is the loss of the choice. Osama forgot how to use the head to kick. So again, I use it faster. Osama, you will left your side horizontal line. Okay? Without arching your back. I don't want knee extension or lumbar extension. I only specifically need heavy extension to make sure that the glutes, you are doing your job, good job. So show me. That's it. So at this stage, because we started to shiver, because it's just using the glutes, it was not working. And he couldn't take the whole range. So it means the glutes here can't. It just extends to middle of the range and can't hold. So the isometric is not good. We can't hold, right? The concentric also is not good because we couldn't go concentrically to the end range. We couldn't. What about eccentrically? Eccentrically is getting back and starting to do, right? So do it again. We will do the hip concentrically, isometrically hold, and getting back in the same position. I'm just showing you. 3, 2, 1, and go. Concentric extension. Hold, like this. Hold. This is checking that. Eccentric
must use another pattern. So cognitive motor cortex here is adjusting. The software is changing. The motor cortex, there are also the choices, brain, and but when I act human, when I talk to the brain in awareness, Usama keeps using the second book, we started to slow down and be specific in the activation. So straight away the test turn to train. If you say yes, you have an easy one. If I examine you the past and the faith based on mark. The benchmark for Usama to say that you pass the test to reach the horizontal line. Sorry again. You're doing a good job. To reach the horizontal line concentrically and hold for 3 seconds and get back to starting position, which is working in the glute concentrically without any help. Separate. So with if Usama, what might be wrong? What we feel, option 1, Usama take exam zero. Fail. Is that a secret exam? Option 2, diffuse patient looking. Pick again. Usama start to west. The lung is on. This is again, fail. Okay? Option 3, when we is back, we started to push from the lung is on. We couldn't control the nice snoring in the opposite. So all the 3 findings, glute max is gone. The very interesting news that each patient will face differently. And the very exciting news that according to how the patient says, you get the exercise. So I give 3 options for 3 patients. Each will say different. But each one will be trained according to the way and the moment it is. And this is the blessing of this approach. It's very safe, very patient dependent. Okay? So let's try the other leg. Harder or better? Better. You can see that he holds with more like easy, no effort and sugar. Okay? So in this case, we also failed because we couldn't go more. So if I want to give Usama the training for this, I will ask him to go for the to go for concentric activity. But if I give Usama training for right, to just go a little bit and hold, because it challenges going as a rhythmic action. Does it make sense? Yeah. Thank you so much. Read the book because on changes. Hamstrings in Usama's case trying to replace the job of this group. Does it make sense? So in your case, hamstring also is right. But the priority as a mobilizer is directus femoris stretch. Right? So patient inflections, these groups are long and good, so I activate concentric centers as well. But on the other side, in the front, mobilizers, rectus femoris, doing too much flexion. Because when the mobilizer is angry, it does too much. It's overdoing. So I want her to less, to inhibit the activity. So I want to stretch. I don't want to exercise or load it forward. I want to come in up. How to do a stretch to the global mobilizer, make the rectus femoris. Come again. You are young fish, species that you know nothing amazing more than it. Do you know the Thomas position? Thomas position. So Thomas position is used sometimes for special tests, but this is not the issue now. So the Thomas position, it's not like this. Come again. Let's refine it a little bit. Come again. Come back. and then roll all the way. So see what's happening? The action of direct stimulus, right? Knee extension. So if I did this, I want to stretch the attachment between the knee. I will need to stay still. It can't. You see? When you do visualization, does the process, especially with that after the kind thing, rebound. So now it's easier, but ideally, patient should be horizontal, not hanging like this. So straight away, you will find the patient substituted with the action of the muscle. It's overaction. Test 20 to 3. So now, rectus femoris is overaction. Finding number 1. Finding number 2, rectus femoris needs to be the back. Finding number 3, from the same position, I will do it, but after the stretch. So I educate positive input, Osama. Keep this position after, which is the position where the rectus femoris is stretched. But I will not do passive stretch. I will hold. So now he is trying cognitively to stretch, break the stretch. Are you feeling it? If Osama is challenging too much, or if my patient, this is too hard for me, shall I stick to just the position? Or I just get enough that this hamstring is tight and it feels heavy. You have an option to resume from testing position, testing and repeat. But if it's too hard, I will do rectus femoris stretching, but from another way. Another position. We will do together. From standing and in the practice, we will choose another position for glutes and rectus femoris. So, how to stretch the rectus femoris? Let's get all stand up. Stand up. Just make sure about the space. Now you are working on it. Because you don't have time to do this. This is easy for you. You find out rebound again. What you turn to this are you repeating everything? So now we have a very basic 40 stretching way to rectus femoris all the activities to do. The chest. Is it right or wrong? Hands up if you find this stretching is a miss. Hands up if you find why not it's good. I don't as I said. Hands up if you will do it. Hands up if you will do another position. Good, 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 good. Thank you for your honesty. You are thinking good. So I would say there is no right and wrong. So care for the people who choose to do it. So care for the people who will not do it, at least with this patient now. Is it already too challenging? Make sense? Maybe this is what we talk about. It's too challenging for a patient now. But for an athlete doing like on field, warming up, preparing for competition, pre-season, very tough. So it's a patient feeling. And the problem with the standing, not this position is bad, but the patient doesn't do the stretching accurately. I'll explain myself. Rectus femoris is attached to the anterior spine to the tibial tuberosity. Cross the knee line and go to tibial. Right? So it goes all the way like this. So I need two bones to get away from each other or to get close to each other. When it comes to stretching, I need the attachments to get away from each other. Right? So what the two bones are close or wide? They are. So I'm pushing the attachment away. But also this is sliding here. So actually the rest is nothing happens. But if I stabilize the lumbar spine, the pelvis, and I push, start again. I have ASIS and the knee drop. To do proper stretching, one is fixed, one is moving. If both are moving, I only moved the lumbar. I did nothing with the side. Can we feel it? Let's do two options. Try to just hold and give your side to the chair. And then just keep your hand on the ASIS and try to take one pencil, one away. The fight. So this is my problem with the athlete or the patient actually not doing any stretching. Make sense? Are you clear with this? So if you have the ability to educate the patient to properly doing it, it will be good choice. If it's hard and challenging, because simply standing on one leg is hard, straight away go to another position. Are you feeling good? I just want you to feel the difference. Again, and go. I hope I didn't feel this time and feel so good. So again, this is normally if my area is loose, I go anterior tilt. So insertion is getting away, but the origin also is getting away. But if I stabilize the origin and push, actually I can go more. I can. So stretching is good, but it's vulnerable. One attachment fixed, one is getting down. So if I don't have a stability on lumbopelvic, the rectus femoris will pull me into anterior tilt and goes anterior and eventually knee tilt. Okay? So I have to make sure when it comes to stretching the long mobilizer, one joint is stable, one is full. Done? And you will feel difference. So now what we will do, we will spread the belly, then the feet here, and my name is colleague, and we will go to another room. 5 beds for 5 groups. Okay, so we will apply the deep group max test and rectus femoris from the thorax position, and then stretching option to rectus femoris and exercise option to deep. Okay, let's go, and I will give floating to you.
Pillow, and the patient lie over a pillow. Okay? So now it's a hip, but relax. I need this. Shh. He is so much guarding. So unlock the knee, unlock the other knee. So drop this. Drop this. Arch your back, arch your back, arch your back. Drop my hand. Relax. Come up. If I find this, I will stop from the hip. Block 1. Proximal, then distal. My colleague is obviously having a control issue over the lumbar spine first. And it's not a surprise. We start by the spine, we go to the periphery. And the related spine to the hip is the lumbar spine. Make sense? Come up. So if my patient is stuck the inflection, this is uncontrolled deflection for the lumbar spine. That's why he is like this. So he has symptoms here and there. And probably refer the symptoms. So now I want you just to feel the extension of the lumbar and the flexion of the lumbar. Like I am arching, looking like pregnant. Anterior pelvic tilt, posterior pelvic tilt. No. Not from the thoracic, from the lumbar. Uncontrolled movement. He can't get out of lumbar flexion. He's stuck, lost the extension choice. Makes sense? So, same idea. It's hard. G, it's hard, the movement?
Yes.
Yeah. So in this case, for the sake of the demo, we will survive, but if it's actual patient, I even will not do the test. So that's why it's important to observe how the patient move, what he use, what's easy for him. It's easy for him to go for the flexion. Get away to the opposite direction, he can't. So hold. I will go for this first. Make sense? For the sake of the demo, we will. What about the hip? Just be relaxed, just hug the bed and relaxed. Because sometimes the patients are guarding, so they do co-contraction rigidity. They contract every muscle. Just relax.
Relax.
And if there is a pillow, it will be ideal for, what's your good name? Abdel Muaid. Can we have a coat rolled? Yeah? I want it at your belly, like your... So patient setup, relax, relax. He has definitely flexion problem with the lumbar spine because it's too slouch, even when he is relaxed. So this is not normal situation. Anyway, so from this position, unlock the knees, just have relaxed. We will test the right first. So kick, do kicking.
Right.
Lift your thigh to the level of plants because the patient doesn't know what about. So I choose simple language. Lift your thigh as if you are kicking. Any more? So inefficient stabilizer. What he did? He did. If you observe. So the problem is not single. So if this patient I see, probably he has a problem with walking. Problem with hip flexion, lumbar rotation. We need control in both. This is a way advanced, but to think more globally. Like he twist. So he's more like when movement is unilateral load, he challenge. It's a lumbar hip mix. If Osama, he has a problem, it's more of isometric, so we need more loading, no twisting from the lumbar spine. So he will have different symptoms. Both failed the test. Are you okay with this? It's how to reason the finding I see. Okay, according to the function, patient complain, I will reflect how he fails. Rotation, or just he can't, it's heavy, he can't. Or he go to the range, but it's challenging. Or he go to the range, but all the way back, he lost. So each will be having specific exercise to the test finding. Can you do the other side, please? But this is way better. Started to do rotation, but he survived a little bit, right? Relax. So now, he is your patient, he is your homework, help him. I will go for 5 minutes and I'll get back. If you trained him good, trust me, we will find another result for the test.
I want to ask a question. If patient is
So if they didn't help you, they will not be certified. I will not give certificate. You volunteered to be a model, so you are important for us.
if patient is trying to flex the knee while extending the hip, then he's using hamstring mode.
Exactly.
What if
This is another way
I've
to-
seen some kind of old patients who are not completely able to extend the hip and either lift the knee also. Then what will be exercises or strategies to?
That's a good question. In this case, I check the passive range of the hip, so I know this is the available range.
Okay.
Make sense?
Gee.
Because some patients are old, so they will fail the benchmark.
They will not be able to.
They will not reach the hip benchmark of the test. I will find their passive range, their available range. Control this range.
Okay.
Make sense? Thanks for asking. It's a good one. So now you have someone needs help. Check the stretching of the rectus femoris. Exercise for glutes. Exercise for rectus femoris from sideline. We did a standing. Now I want from sideline, but test from Thomas position. Have a go. Yeah. What is the question? And I will decide when I will answer.
Which one? But because I have a lot of questions.
We got up till
Up till this inter-relative.
hip knee relation.
Hip knee relation, specifically the pain.
Okay, so we will go through this in the demo. What else? Hip spine, as you see,
As you see, yeah.
definitely related.
And
Exactly, iliacus anatomically control the
what about the
pelvis. and do hip flexion with
Yeah.
pelvis control.
You talk about the glutamax and
Iliacus.
iliacus. What about the QL? QL, quadratus lumbar.
It's a mobilizer
Some mobilizers.
among the lumbar spine, but nothing with the hip because it's attachment iliac crest. So nothing with the hip.
But whenever we do hip extension, the first glutamax, then hamstring, then the contralateral side of QL will be ideally activated.
Overactive.
I have a question.
So where is the question? I didn't get.
No. I'm telling you. The thing is, if the mobilizer gets overactivated, it is important that it gets always in a shortening position. And sometimes, because I have seen sometimes they are lengthen position, because in lengthen position we can't do exercise.
Give me example so I can understand.
Yeah, if sway back position.
Huh?
In sway back.
Sway back.
जो our mobilizers, the one is in practice femoris, we get lengthened.
Lengthened or landed?
Could you kindly clear the time because that candidate had an emergency to leave.
Emergency with the
No worries. It's okay, just give me a pen.
Kindly sign.
Thank you. Always ready. Oh, that's a good one. I will borrow it. A lot of questions, so just to take the questions. Okay, so thank you.
In sway back position, this
Iliacus is inhibit.
iliacus is inhibit. And what about the rectus femoris? Nothing happens with rectus femoris. It's totally
Hamstring
fine.
is tight.
The hamstring is tight. The short one. The short
Exactly. Because it's taking posterior tilt. So it's a hamstring pulling from here. Iliacus no control.
We do.
Yeah?
Actually, most of the female
Yeah. You okay, Osama? Good. How do you think about their answers? Which is which? Wow.
हाँ खुद रिकॉर्ड कर ले भाई और बहुत ज़्यादा लेगा
So let's get back on track. So now we have good news and bad news, actually. Which one to start with? The bad news. The bad news, right? The psyche of the people is negatively biased, right? If you want to do the highest reach of Instagram, start with negative hook, right? So make a negative hook to start to attract the patient. So this is something psychological. Anyway, I will start with the good news because I'm a positively biased person. So the good news is that in the practical, you are engaged, so you did really a satisfying job. I feel that you started to correlate already, hopefully. The bad news that we only have 20 minutes left, so we are ending the session so soon. Bad news for me. So where we are, we were training the global stabilizer as the main responsible brake system for control. Why this important? Because this improved the timing hold, like in case of Osama. The training will have later on timing hold, and this is important function of the global stabilizer. It will reduce the compensatory strategies, because if Osama have active glutes, he will not push on the lumbar spine or kick with the knee. So I will not find substitution of movement, and therefore I will have different movement pattern. I will have another option to extend than pushing from the back or kicking by the knee, isn't it? So when you train any problem of the causes of uncontrolled movement, you help the overall movement. If you stretch the rectus femoris, you help the overall movement. If you help the stabilizer, same applies. Okay? So what I want to say that working on element will correct a lot of other problems. So just make a start. Last 10 minutes, I want to integrate the kinetic control into the musculoskeletal framework. Reasoning. We know how to test control. Now when? According to the musculoskeletal framework assessment, we have two parts: subjective examination and physical examination. Subjective examination is talking with the patient, collecting data. In interview, structured interview. 7 questions, main 7 questions. This is, you join the OMTC, you explore in depth, but as a brief map, I ask the patient certain questions to reach a decision, to decide. This patient is having any red flag that prevent me to treat him? Is the problem it's coming is really musculoskeletal related? This is question A I need to answer myself. Reason number 2, I do subjective examination. Is the pain is mechanical or not? Increase and decrease by movement and load and the positions or not? If the answer is yes, you are mine. This is the happiest news for physio. If function increased with movement, your kinetic control approach is successful because we work on movement. Make sense? If it's vague, maybe I need to refer, maybe systematic problem referred to joint, maybe something not related to physiotherapy. Maybe something really serious I need to screen first. Are you okay so far? So this is the goal of subjective examination. As for the physical examination, now the patient is safe, I can continue examining him. Big 5, physically, one-to-one, I do with the patient. Active range of motion, show me your active range of motion around the problem. Passive range of motion, I do over pressure. Repeated movement test, how the repetition of movement affect the symptoms. Neurodynamic tension test. And finally, cognitive movement control testing. And this is the block related to the kinetic control. So I will not check the movement. I check the active range, the joint. The passive range, the joint. Neurodynamic tension test. Repeated movement or the neural pain, the central element, repeated movement like lumbar spine or cervical. Okay? And finally, after assessment and treatment of the first 4 blocks, I target which the movement testing. Are you okay? So maybe you go step by step. Sometimes I work on active range of motion and cognitive movement testing and the training. But just to be aware that there is different steps of the assessment and the management. Cognitive movement control test is like block 5. It's one of 5 stuff. Are you okay? So this is when it comes to assessment. So cognitive movement control test, patient has a problem with movement, okay? Like every time I walk, I bend the hip. Every time I bend the hip. So this is problem with movement pattern and or problem with muscles for this movement. I'm just recapping. Are you okay? Can you correlate this? So when I have cognitive movement control test problem, it means that the movement is not proper. It's just single option, just too much for one joint. Movement pattern, not good. Plus muscles, stabilizer, mobilizers, locals, are not functional. Are we okay so far? I'm just recapping what's cognitive movement control test. Movement pattern, I observe wrong. So I want this movement pattern to change. And this is through muscles, one by one, work on them. Whether it's a stabilizer, whether it's mobilizer. And this is what you did already. Are you okay with this summary? Okay, so this is few evidence about how the motor control retraining histologically do changes on the central nervous system and how the neuroplasticity happens, like the motor cortex mapping started to change in the faulty, unhealthy situation, overactivity of mobilizers, inhibition of stabilizers. But by retraining, the central nervous system responds and start to do the right activation for the right muscle. So he is not overactive, he is not giving over signal to mobilizers. And he is not forgetting anymore the stabilizers. What we did with Osama, we started to, Osama, get it here. Push from the hip. Feel some tension around the sitting bone. This cueing, this sensory information, the motor cortex start to respond. Are you okay? So this do changes according to research. How? 2 minutes training for the stabilizers twice per day. So Osama has to do this kickback with focus, with pushing by the hip, 2 minutes morning, 2 minutes evening, for 8 to 12 weeks. So I can find this research finding. Like if I took MRI for Osama before and after 3 months, I find centrally changes in the motor cortex. I find that the brain do the movement with deep glutes and not pushing with the hamstring. Hamstring is relaxed, glutes is active. Are you okay? And this is the protocol or the guidelines showed by the research to make a change, not just feel the relief or not just no tightness anymore. Are you okay? Sorry? Actually, this is a good question. Because the rule for the kinetic control testing, that the movement that I test, it should not be painful. Because if there is pain, it's very hard to do cognitive training. The central nervous system will not think about movement correction if there is pain. Emergency, lights on. I'm not free to move accurately. So that's why we have first blocks, go for active range of motion, testing and the training, or test and the treatment. Do your nice mobilization to less sensitivity of the joint. Neural tension test and the neural mobility, if this is the cause of the pain. And after the patient is only stuck at movement pattern that leading to pain, now this is the phase of rehab, I use kinetic control. But my short answer is no. It should not be painful or severely painful. In the advanced situations, I use the kinetic control to inhibit the pain. Because if Osama, we did the deep glutes activation, Osama, how it feels? Relief. Because when I start theoretically and clinically to activate muscle group, other muscle groups relaxed. Like I started to distribute the load. So the mechanical overloading on the passive tissues is now relaxed. Other muscles carry the load when I did activation. Make sense? So again, there is no right and wrong. I'm giving you the ingredients, you do the recipe. Yeah? So it depends on the test and the training. Maybe training is really easy for a patient. And maybe training is really high. So the patient irritability can't take it today. For example, if my patient having high level of hip pain, I will not start with this. This is a test, but I'll start with retraining straight away. So I know that, yeah, pain inflection, so I know that according to this map, deep glutes is affected, deep glutes needs activity, but the test position is too challenging for the patient. I will not do it. I will start by treatment, like very gentle glutes, very, very gentle one. For instance, just kick back, very gentle. And when symptoms is better, I do the test as a measure, because he will fail anyway. Are you okay with this? So this is a very good point. So if you feel confident and the patient is engaging like Osama, he can adjust, he understands you, carry on. If it's too challenging and he only thinks of pain, I think you will need some other approach. Make sense? So why kinetic control? It's a clinical. It's tailored to the patient. It's very tailored. Which function was the problem? How you do this function? Which pattern? Which region overloaded? Which muscles need to do their job to offload this joint? Does make sense? So it's a very clinical, very tailored. Do the test, he failed. How he failed? So how we train. Are you okay? So testing turned to treatment, which is tailored to patient. Cognitive, the idea that the concept or the exercise is cognitive, you are talking to neuromuscular approach. It's not just muscle strength. It's not just the peripheral. It's you talking to the central nervous system. It's a neuromuscular. Because the cognitive input means the manager, the brain, is giving different orders. You are making changes on the central level, not just hypertrophying of the muscle fibers, which is a strengthening. Makes sense? You educate the brain to master the movement, to give a specific movement accurately. So the idea that the training is cognitive is of high value. And guess what? Back to your question, distracting the patient from pain. Yeah? So focus on movement without pushing on the region of pain. Make sense? So, this PowerPoint is for different intakes, so no problem. If I want to give one term for what is kinetic control, it's person can control specific movement at the right joint, right time, with right load. Right load, low threshold task or low force load in case of stabilizers. patient coming with pain in just sitting, this is low load problem. Stabilizers. I don't need mobilizers here. This is not the right activity for the right load. I want to do kicking, I need mobilizers. Okay? So according to the load, I need the proper muscle activity, whether it's stabilizer or mobilizer. And for the right time, as for Osama, he decided to start with hamstring. This is not the right time for hamstring to get in. Makes sense? So the right region, hip joint, in case we talked. The right time. So if I want to push by glutes, it's not the right time for hamstring. Okay? Wait. Hamstring, you wait. Glutes, take the lead. And right load. Because I just want lifting thigh, I don't want kick back. So in the low load, glutes should jump in, and no involvement, no substitution from hamstring. It's not the time for hamstring. Are you okay? Last but not least, what's next? I just want you all know that this is an introduction for a big program. The Kinetic Control, KCMT is a Kinetic Control Movement Certification. This is the official Kinetic Control program. How it happens? It happens in 8 days. So you have to attend these 8 days overall program. They are separated into 4 days and 4 days. We don't take them as a one shot. And afterwards, there is 2 days master class, but these are elective. If you finish the 8 days, you are done. You are done with the certificate. But later, you can take master class if you wished, okay? So these 8 days, 2 main blocks, 4 days, low back and hip, and other 4 days is cervical shoulder. In these 8 days, we have six modules covered. Okay, 2 days, we talk about coordination, 2 days muscle synergy, block 1. Block 2, 1 day cervical, 1 day shoulder, 2 days local stabilizers. So this is how the program is structured, and you will take certification for each module, okay? So this program finalies happened in more than 14 countries under Prime Physio umbrella, because Prime Physio and Comera are the international official institution for teaching the kinetic control. And these 17 countries included Pakistan. It has just happened this month in, I think, Lahore. So we hope to see you at some point. Finally, this is how to reach us. So this is QR code if you want to scan. This is a Prime Physio website. So you can always follow our upcoming activities. And finally, what happens here? Really? Okay. So finally, this is how to find me. Under this name, you will find my LinkedIn account. This is the most platform I am active at when it comes to professional activities. And this is my email in case any of you wanted to share a case, to share whatever. I will be happy to hear from you anyway. Thank you. I'm so happy to have your attendance today. So now we will have the certificate and the group photo if you wish. Right? Thank you.
Okay, so we are now proceeding to the closing ceremony, like closing of the event today. And I would like to thank all of the participants and honorable guests, Dr. Nazi Josefa, Dr. Ibadur Rahman Khanwari, Dr. Ahad Hassan, and Dr. Rafia Rafiq. She left for a while. And special and a very special thanks to Dr. Farhan Ishaq. He is our advisor, and he helped us in organizing this event. So, sir, thank you so much. Thank you, SBU, the management of the SBU, Saifee Burhani University. Unfortunately, they are unable to attend this event, but they helped us a lot, and they stand by our side to make this event in a better way. So, I would like to thank Dr. Rasha, especially Ghani Physio and team, and Prime Physio. Okay, so we are now here for certificate distribution, and I would like to call Dr. Rasha on the stage. And sir, Dr. Farhan, please.